Hi everyone, this is Fern Gilkerson, Health Education Specialist here at PCADV.
Good afternoon everyone, this is Jan Davis, Contract Monitor.
So thank you so much for joining us on this beautiful day for our webinar using the HELPS tool, Traumatic Brain Injury Screening and Referral.
Before we get started, I want to take a few minutes to congratulate Fern for being published as a co-author on an article that's recently issued in the Journal of School Health. This is in the July 2017 issue, Volume 87, Issue 7, and it's on school nurse-delivered adolescent relationship abuse prevention, and it's regarding the Project Connect. So check that out. It's free. You go to wiley.online or onlinelibrary.wiley.com, and you can download that article. It's very informative, and it provides some evidence-based research to back up the outcomes of Project Connect.
Thanks, Jan.
You're welcome. I also want to let folks know that PCADV has a brand new app out, Raising Respect, and it's designed to give parents of teens and preteens advice on how to best discuss topics around communication and relationship. The app is free. It is available for Android and iPhone. And that is a product put together by our prevention team. So we want to send out thanks to Kristen Herman, our prevention manager, and the members of her team. So now we're going to get started.
Yay. Okay, so as hopefully you saw in the registration and invitation, that the recommendation from PCADV was that webinar participants would have at least 2 people from the program participating today, including a trainer and an advocate, and have printed the HELPS tool and the program screening guide in advance of the webinar today. So we hope that on this webinar you get your questions answered, we have fun, and we learn some useful things. Chris, Jan, and I, many of you we know, but many of you just know our voices and not our faces. So if you need to contact us, those are our emails and phone numbers.
Okay, so these 4 general goals are related to today's webinar. We're going to learn how to comply with Section 8.4 of the PCADV standards, which talks about using a traumatic brain injury screening tool, 2 ways to screen for TBI and to make appropriate referrals to a local healthcare provider, procedures for administering and reporting the number of TBI screens your program performs, and what to do with a completed HELPS tool. Is there anything else you were hoping to learn in this webinar? If there is, can you please write it in the chat box? We'll just take a few seconds for folks to do that. The first thing that we are going to put you through is a quick poll. So let's move on to the next slide.
Right. And so what we'd like to know from you is, does your domestic violence program refer for traumatic brain injury and screen for traumatic brain injury all or most of the time? And Susan, yes, I will give you a phone number that you can call. It's the Brain Injury Helpline, and it's administered by the Department of Health, and they will be able to connect you with providers in your region. They will be able to tell you who to call and who would be on their list of providers for brain injury rehabilitation in your region. All right, it looks like we have a little over half the folks on the line saying that yes, all or most of the time, a little under half saying no. Oh, now it's changing. Okay, and we have very few who are saying that you don't know, and that's okay. And we still have some results rolling in. Thank you, everyone, for participating. This is extremely helpful to see.
Okay, so we have about nearly half of programs telling us that they are using the HELPS tool. About 48%.
Right.
And the no's are 43. The I don't knows are about 9.5.
Right. Great. Those are wonderful numbers. Thank you for participating. So let's go ahead and move on, and I think we'll just have those numbers in mind, as we go through this webinar to try to, think about how we're going to talk about and what way we'll talk about the information on the slides. All right.
Okay, so why does PCADV require screening? Well, we know experientially that folks who come into shelter or who come in for service have experienced some kind of head injury. You can see from the graph that 92% have been hit on the head more than one time. 83% hit on the head and severely shaken, and 8% have been hit more than 20 times in the past year. We know this. These are good stats, and it's a huge concern for us because in order for us to be able to provide the best service possible, we need to assume that most of the folks who come in for services and shelter have encountered some kind of head injury, and that our screening and our making appropriate referrals could help them get proper medical assessment, a diagnosis, and the needed services and rehabilitation that an external health care provider would be able to give them.
Exactly. And I think that as domestic violence advocates, we all know that we're in the business of working with people to change lives, and screening for traumatic brain injury in our programs and making those needed and appropriate referrals could be life-changing and also transformative for our communities. So that's why PCADV has really embraced this, this requirement in the standards, and really want to do all we can to support you in doing this the best that you can.
So you might ask, what does Section 8.4 of the standards state? And as the compliance representative here at PCADV, I will tell you what that says. All adult residents will be screened for traumatic brain injury and referred as appropriate. The program will provide training for all shelter staff on the signs, symptoms, causes, and impact of TBI. And I would add that although the standard talks about shelter staff, it really would be any staff or direct service volunteer who do intake and screening, who make assessments for shelter eligibility, who take hotline calls, to have some idea what the questions contained in the helps tool are, and work on incorporating those into all standard hotline or face-to-face intakes.
Right. So just to give a recap, programs will need to make sure that all staff tasked with or responsible for those tasked with intake, counseling, or advocacy are properly trained in traumatic brain injury and domestic violence screening, response, and referrals. You will need two types of screening tools at the ready in your program. One, of course, is the helps tool, and the other is the conversational tool that we're calling the program screening guide. And also that you have a working partnership with a referral agency for traumatic brain injury. Again, as I mentioned earlier, I will give you the number for the brain injury helpline, which we recommend that you keep at your desk and keep it right there so that you have it at all times and available to call them and, ask for whatever help you might need. I do want to qualify that the brain injury helpline is not a hotline. You will most likely end up leaving a message, so don't rely on it for hotline purposes. So what is the purpose of screening for traumatic brain injury in a domestic violence program? It is to alert your survivor that you're working with to the possibility of traumatic brain injury and that they might need a medical assessment for this purpose. The screening process is meant only to initiate a conversation about the survivor deciding on their own if they need further medical care, and it's also to provide better advocacy services for the survivor. You'll want to discuss concerns and work with them to connect them with a provider if that is something that they want. And, you know, we really have to say that you must not diagnose someone with a traumatic brain injury even though you're conducting a screening. Since we're not in the profession to do so, nor do we have the proper medical licenses to do so. So we do not in any way want to imply that advocates and other types of service providers who are not medically qualified should or could medically assess and diagnose for a TBI. Conducting the screening and bringing awareness to the fact that someone could need follow-up could make all the difference in the world for someone, however.
And I just want to address Marcella's question. We will be getting to that shortly, so hang on with us. We're getting there.
Yes. So, again, unless you're a medical doctor, you know, don't presume, diagnose, assume, or medically treat TBI. Your goal is to assess the possibility and connect with someone who may be able to actually provide a medical assessment and diagnosis and to provide services for them. So moving on, we'll review the two tools that do meet the PCADD standards in a bit, and we'll do that in more detail, which, as we said, are the HELPS tool and the program screening guide. Sometimes I will refer to that as the PSG. Just to begin talking about these tools, the HELPS tool is a brief intake tool, and the PSG is a conversational tool. It's likely that you will use them in this order if your program chooses to use both. And I want to say that although programs are required to administer a screening with new adult emergency shelter clients, we do recommend conducting both forms of screening for every survivor just to be consistent and to make sure that, you know, you're also touching, you know, those who are walk-ins and, you know, just not only the folks who are residing in shelter.
Right, and I just want to add that the standards talk about adult shelter clients being the ones that you must administer the HELPS tool on. We recommend, however, that to provide the best service and referral process as possible, that you do the screen on everyone with whom you have a counseling session to see if, in fact, they may have suffered a head injury that would require you to make a referral. We're going to talk about how to document that information to PCADV further on down the road during the webinar.
Right. But we also want to make clear that this is not a recommendation that we are having for your interactions with children.
Exactly. This is for adults.
Right.
Do not administer the tool to a child.
Exactly. So let's move on and look at the HELPS tool. And as I stated before, it's a brief screening tool to be used with, you know, all program participants, adult program participants at intake appointments. It's meant to be short, but not delivered in checklist form. It's really meant to be a guide for a brief assessment. And when doing this, make clear that to the survivor that because injuries to the head are so common among domestic violence survivors, that you're now asking some important questions of all program participants. That's really important to make sure that you communicate that it's universal with adults and standardized and that you're not singling them out. So let's just go through and really talk about each section And again, it's not meant to be delivered as a checklist, but I do want you to become familiar with each of the sections so that when you are using it, it comes across naturally and it comes across, really very comfortably in your delivery. So you'll want to first talk about, was your head ever hit or jarred, and did you sustain any injuries to your head or neck that you can remember? This might include being bruised or drowned, or were you ever suffocated or strangled? And of course, however it feels natural to deliver this and in the most trauma-informed way possible. The E stands for emergency. You'll want to ask if they've gone to the emergency room or sought emergency medical attention due to the actions of another person, including an intimate partner or a relative, and how long ago was it, how often have you gone, did you ever feel that maybe you didn't seek it out, but you did have this type of an injury. The L is for losing consciousness, and for those of you who have been in the full day trainings, you've heard this before, but for those of you that have not, loss of consciousness is not a necessary indicator of a brain injury. But when someone has been hit on the head and they do lose consciousness, we do move to, the thought that there has been a brain injury. So it's not a qualifier for brain injury, but if they do lose consciousness from a knock to the head or falling and hitting their head, then we do want to sort of keep in mind that they likely have had or have a brain injury. I hope that makes sense, and please put it in the chat box if I'm not being clear right now, because it's a pretty important point.
And to answer your question, Colleen, persons 18 years of age and older are considered adults. So adult shelter clients ages 18 years and older would need to be administered the HELP tool.
Okay. So for the first P, we want to sort of revisit, the idea of, have you had any problems in the head or neck area? If so, why? And, we kind of circle these questions a little bit in this way because, there may be memory lapses, there may be trouble pulling together thoughts the first time that you talk about something, and so, it's useful to kind of ask the same sorts of questions in different ways. They may have brain fog, and it may not, come up the first time that you ask them. So if it seems like these questions are a little repetitive, this is why. And then the second P is, are you or could you be pregnant? This is important for safety when someone is pregnant and may be at risk for brain injury or has had a brain injury. It can affect the way they eat, which would affect their nutritional intake and could affect the baby if they're not having proper nutritional intake. Other life circumstances could be compromised or risky due to an expectant mother having or possibly having a traumatic brain injury. She may not be going to prenatal appointments and getting the proper medical care. It just may not be something that is registering in a way that someone who doesn't have a brain injury may be taking those steps towards having a healthier pregnancy. Let me look at the questions really quickly. What is the reason behind us not asking children? In the full day training, we do have a children's section, but mostly we talk about the way it impacts children and the way that we can work with children. It's just not, these tools are just not tools that are validated for children at this point in time. So while we train advocates to work with children in this way, that's why we're not conducting the screening and referral piece. It's just not validated. And Colleen, I hope that makes sense. Honestly, it probably just boils down to, we don't want that type of probably responsibility, for having that assessment for children. Jan and Jeff Sterner is also in the room, folks, so I would like to see if you two have anything to add to that explanation.
No, it's my understanding that the validation of this tool was not performed on children. So, I mean, that's pretty clear that we can't recommend it as a valid tool to be used with kids.
Mm-hmm. Right. Are there any other questions about the HELPS tool before we move on to reviewing key points of the program screening guide?
Can this is Joe Sterner. I just want to jump in for 1 second about children. Just because when programs are not required, nor should they be doing the screening for children, it still is important to have the referral information available in case the adult parent with the child, they feel that there's something going on. So it doesn't preclude you from offering referral sources for children. It's just, as Jan and Fern have said, that tool is not designed for children.
Right, and if you need information on how to work with children and how to understand children who may have had or have a brain injury, and I will show you how to access the toolkit later, but in the toolkit there is a section, and in the participants guide there is a section just dedicated to babies, children, and teens. So it looks like a couple folks are typing, so let's see what your question is maybe before we move on. Yes, thank you, Ashley. Brain Steps is a Department of Health funded program that is a school reentry program. They are a liaison for students who are reentering schools and have experienced brain injury. They are not an advocacy-based organization, so it's clear to make that distinction that they're not advocates, but they're liaisons, and they're there to help lay the best plan for school reentry. Right, Susan, thank you, yes. So you're also aware of Brain Steps. And they are a very useful agency, and I think they're very good to have at your ready and on your radar. Okay, so let's move on to the program screening guide. I just will review a few key sections here because it is a longer conversational guide or a tool for counseling and advocacy-based sessions as opposed to the HELPS tool, which is more for an intake session. And after a couple times of reviewing this tool, I think that you'll likely become pretty comfortable and natural with the delivery of the discussion points. But we've just pulled a few pieces here for, just exploring the reasons for some of the sections and how to kind of smooth them over when you're using this approach with the screening requirement. So you'll see that there's a section that discusses whether someone's hungry or thirsty. And you'll really want to begin by asking someone if they're comfortable and to make themselves comfortable, and other warm-up questions that may help someone, whose presentation could be mistaken for someone who may have a traumatic brain injury. This could be fatigue, it could be brain fog or inattention or a headache, but, it could be caused or worsened by hunger or dehydration or even caffeine withdrawal for some folks. So we ask if they need anything to eat or drink. If possible, keep some snacks and drinks available at your desk, granola bars, water bottles, if you can run and get a quick cup of coffee. So you just have that there if they're thirsty or hungry. This really does serve the purpose, again, if they're not thinking straight because their blood sugar's low, and then you assess them as maybe needing a traumatic brain injury referral, that could really skew things and mix things up. So we just want to make sure that's taken care of up front. Then we move into asking things that should be present in a survivor's short-term memory. They should be able to talk about their children and their pets. Do you have children or pets, and what are their names and how are they cared for while you're here? How did you come here today? What happened before you came? So you're really listening for a survivor's trouble in remembering and finding words to answer. However, if through the discussion you find that someone has not provided care for their children or animals, you'd absolutely want to discuss how to do that and what needs to be taken care of immediately. But, you know, these short-term things are addressing questions that someone without a brain injury would not likely forget or have brain fog or have trouble articulating. So to you, it could be a cue to you that there may need to be a connection made to a brain injury medical provider or center. And the last part of the PSG that I'd like to focus on is talking about the situation more specifically and to learn about the specifics that may have caused a traumatic brain injury. These include questions along the lines of, let's talk about some things that may have gone on in the past. You know, do you know if you were ever hit on the head, mouth, or maybe other places on your face? Were you shaken or pushed so hard that you hit your head? Do you know if you were ever injured in the neck area, strangled or suffocated, and so on? So these are really important questions to kind of work into. And again, you know, this is not meant to be read as a script. It's not meant to be a checklist. It's really meant to be something that you naturally learn to use and deliver as screening questions in a conversational way through your sessions that you have with survivors. So because the HELPS tool and the PSG are meant to be used with cultural competency, we're going to spend a little time looking at what it means to, you know, understand culture, cultural biases, and assumptions, because those do, whether we like it or not, and whether we know it or not, will influence the way that we deliver services and the way that we listen and respond to survivors and their needs and their situations. So we have two slides here where we're going to just work through this just a little bit. So I'd really like to hear from you all in the chat box some examples of things that represent culture. And then we'll review those and take a closer look. So what to you represents culture? So we've got food and family.
Clothing.
Spirituality. Views on treatment, yes. Communication, traditions, religion, food, music, belief systems.
Parenting style. Norms about family size, language, traditional living situations, family dynamics.
Art. So it looks like we have a couple more examples coming in. Definition of what is acceptable within a relationship. Boy, we can get real hung up on that, can't we?
Who we consider family, yes.
Medical care choices, yes, exactly. Yes. Thank you for this list. I think this is a really great list. I think it really captures a lot of what we're seeing represented as culture. We might also want to add to that how we wear our hair, our personal hygiene, maybe how we speak, our income level, of course, race, nationality. So we can recognize that these things that we just listed may represent attitudes, behaviors, customs, or beliefs that connect us or distinguish groups of people from each other. And when they do, we consider it cultural. So, you know, we need to really understand this, because as advocates, we may have preconceived notions about what someone projects, you know, or what we perceive about a survivor's culture that could impact a screening, could impact our response, and could impact how or if we connect them to a provider. So for ourselves, we want to tune into ways that we may be doing this and work on not having this happen, and pay attention to the person and what they say and what their personal beliefs may be. It's not always easy. It's a lot of personal work, and it's not always obvious. So, we also want to understand that a person's, a survivor's personal belief system may mean that they do not opt to accept a screening, accept a connection to a provider, or accept medical care. And I really like that we have some folks address that. They have the right not to do the screening. They can stop it, and you have to stop. They can say, I'm not doing, what you're asking me to do by connecting to this provider, and we cannot put conditions on our services because of that. So let's just move into a little bit more about cultural competency, and I'd love to hear your ideas of how maybe cultural awareness is important to screening. So can you please go ahead and share your ideas in the chat box? Gendered language. Right. Anyone else want to share how cultural awareness may be important to screening? Great. I see multiple people are typing now. Perfect. Impact eye contact. Good one. So Susan says while we need to be inclusive, we have to respect those who have strong ideas or beliefs otherwise. Absolutely.
Amy,
Yeah. Go ahead.
Amy, great point. Folks may not go to the emergency room. They may seek medical advice elsewhere. So if there is a traditional healer in the community, that would be a very different situation and versus this traditional kind of medical screening.
Absolutely. Someone may choose to go to an acupuncturist over, the local brain injury rehabilitation center, and that's okay. Someone may choose homeopathy, herbs, or yoga. That's okay.
Or a curandera, if
Right.
there is one in the community.
Exactly. Oh, what people choose to eat or not eat? Yes. Deborah, thank you. And that's an interesting one. Also, and just going back to the theme of the webinar, appetites and food preferences can really swing with a brain injury. So that could be multi-layered in a couple different ways. So what we want to do is never stop working to develop an endless comfort level, and no matter what, continue to let the survivor drive the bus. We've been saying that for so many years, and we don't really hear that phrase, I don't think, that often anymore, but that's really our goal with this. In essence, we still have to be able to provide good and thoughtful services in the context of cultural differences. And the process, I think it's fair to say that the process of checking yourself is ongoing and ever evolving. And as I mentioned earlier, we can't put conditions on what someone chooses or the outcome of a TBI screening. And we can't, punish, negotiate, or bargain with them. And even if we feel they should get some kind of standard medical care, as Jackie Stutz, one of the trailblazing mother advocates of the domestic violence movement in Pennsylvania, used to say, she said, we should not should on people. I love that. I love that phrase. We should not should on people. So, people have a right to do what fits their preferences and where they're at. So it's very helpful, and here's the number I talked about earlier, the Pennsylvania Brain Injury Helpline. It's very helpful to have this posted throughout your counseling offices. Just have it right there. Again, it's not a hotline, it's a helpline, and you'll probably leave a message, and I'll probably have to call you back. but they do have a lot of resources at their fingertips for referrals. So there's also, we're lucky enough to have a Brain Injury Association of Pennsylvania. They have a lot of really great resources online, but if you need to call them, they do have folks who will answer the phone.
Fern, is the Brain Injury Helpline associated with the Brain Injury Association of Pennsylvania?
No, but I bet you that the helpline would give the Brain Injury Association of Pennsylvania as one of the resources.
Okay, great.
But the helpline is a project of the Department of Health, and the BIA of PA is their own entity. And the Brain Injury Association of America is another really great resource. So yes, Shelby, you will get a copy of these slides. Absolutely. Absolutely. And I see that Gianni has answered that also. So are there any questions so far? Any more questions from folks at this point in time? All right, we will move on then.
Okay, so this is the million-dollar question for the monitor that I've been talking about with folks during site visits over the last 13 months. And what do we do with the screening tool? Yes, we've done our help screening. We've made referrals. What do we do with the paper helps tool? Okay, so that form belongs to the survivor. It is about the survivor. It is about information possibly that could be related to the survivor's medical situation. It's an informational tool. The responses, the advocate may write on the form what the responses are. The client may write on the form what the responses are, but that's the client's form. So don't keep the form in a client's file. You really, absolutely ideal practice is not to hang on to the form at all. Now, I know for folks who've been working in programs that the concept of not having a form which has been completed in the client's file can be difficult. What you would need to remember is that the information that's contained in a client's file is a record of service. So you would need to be putting in your case notes that you administer the helps tool. We're going to be talking about how you document that in ETO shortly, but there would be something, or completed traumatic brain injury screen or TBI screen, that can go in a case note. You're not giving any information away, but the form itself really needs to go back to the survivor. I've talked with programs occasionally about if the survivor doesn't want the form, what do they do with it? You can put it in a crossover notes file or a shift log if you feel you must hold on to it, but really you don't want to hold on to that for any length of time. I've had folks tell me that they pull the helps tool out of the client's file when the person exits shelter, but people forget to do that. So it will sit in a file and really shouldn't be there. So my thing for all of you to consider is giving the form back to the client and indicating in the case notes that you administer the TBI screen.
Jan, can they also shred them if the survivor does not want to take it home because the abuser is there?
Absolutely.
Okay.
You know, you can also get creative about what can you provide, and this is a question for you all, can you provide an electronic copy to that survivor safely that they could keep in their phone or on the desktop of their computer, again, in a very safe way where she could have that but not necessarily have the paper?
Mm-hmm. Right, and we have another question from Colleen, a very good question. What if the victim is calling on the hotline?
Right, so ideally, if the victim is calling the hotline, you're not going to have a paper to provide. You may have a paper for your own notes, but it would be the same thing as far as documenting in your case note that you did a screen, and if you did complete a form while you were on the phone with the survivor, go ahead and shred the form.
Mm-hmm. Sure, and conducting the TBI screening on the hotline is not part of the standards. So just to be clear about that, if you want to, if it seems appropriate, certainly you can do that. But nobody is, going to come back on you and hold you responsible for not doing TBI screenings on the hotline. We see that Ashley says that you've implemented this at Laurel House. After the HELPS screening, you do a program screening, which often results in a referral to a local TBI program, which Moss Rehab is the one that you referred to, Ashley. You typically help clients contact Moss Rehab for the referral, and you have to get an ROI sign to do this, but you keep it in the file. Is this okay?
Yes, it's absolutely okay, and thank you for mentioning the release of information form.
Yeah.
Yes, you do, this is with any release of any information to an external entity, get your consent form signed and make sure all the points within that form are properly completed.
So Colleen, backing up, you're asking, you thought you were supposed to screen all adults. So if we go back, let's back up to our slide about what the standards say. All adult residents. So they may become residents once, if you decide that they're appropriate for shelter. But as far as them being on the hotline, they're not yet residents. So that's why it's not required to conduct a TBI screening on the hotline, because they're not yet residents at a program. Once they become residents, yes, then programs must follow the standards. Does that make sense? Yes, and Ashley, the way that you have laid out that Laurel House does the screenings is, I think, a good model and a good flow to follow. So thank you for laying that out. So that helps tool, yes, the standards say adult residents. So you are getting that correct. It's just for shelter residents. However, Jan and I did qualify earlier that it's good practice to universalize it with those who are counseling advocacy walk-ins. If it's appropriate, if it seems appropriate to do over the phone during a hotline call, feel free. But the standards only require for adult residents of programs. So those of you who have programs where there's no residency opportunity, again, you can skirt these standards in the way that, you can universalize it, you can provide it, you can do the screenings, you can do the follow-up, you can do the referral, but it won't be held against you because you're not, a residency program.
Right.
Thank you for asking. Yeah, those are really good questions.
Yeah, they are. Thank you. And just to clarify, emergency safe house could be several things. It could be a safe shelter that you run yourself. It could be a hotel or motel to whom you refer clients, and you have a separate procedure for getting them into a hotel, in an anonymous or confidential manner. So all of those are considered emergency safe housing. All righty, let's move on. Sometimes I love my job, and this is one of those times when we talk about compliance and how do programs demonstrate compliance? Okay, so if you have an adult shelter emergency safe house resident, you have administered either the paper helps tool or you've used the conversational guide, you will need to track this information in ETO. So we're talking about adult safe shelter residents and administering, using ETO to check that you have completed this. So for case management programs, there is a new Track Direct Services effort, and I think it's the very first one on our Track Direct Services touchpoint page, Administered Helps tool. You check the box. There's no time associated with that. That touchpoint acts like the administered or provided or distributed the ESQLF. So you check the box. That will map to your monthly report as a total. For aggregate ETO programs, you will have a little box in your reporting form where you enter the total number of helps tools administered for new adult shelter clients each month. So again, you check off either the administered helps tool touch point for case management, or you enter the total number of helps tools for aggregate programs each month. Both of those you need to track for adult shelter clients only. The terms of our funding for this particular project on TBI in our agreement with the Department of Health was that we report back to them the number of adult shelter clients who were administered the tool.
So Ashley has asked if we should be tracking the PSG screenings, and will there be a new box to click similar to the Administered Helps tool? You know, we just want to know that each resident has been screened at least once. You don't need to count how many times you screen them. So whether you use Helps or PSG, you know, just click on ETO that you've, you know, conducted a screening with this person. Jan,
Right.
do you want to?
Yeah, it doesn't matter which tool you use, whether it's the Helps or the PSG. When you go to record that in ETO, just check the Administered Helps toolbox.
Right.
And that'll cover both.
Right, and you don't need to sort of double dip your numbers with PSG and Helps. It's one time, one check mark per person, but we do encourage multiple, multiple times for, to ask. So Marcella says,
wait a minute. Oh, I'm sorry. Go ahead.
okay. So Marcella says, so this will be an independent touch point that we will have to input, not a checkbox with another touch point. Do you mean in ETO, Marcella?
I'm not sure I understand your question, Marcella. There will be on your Track Direct Services list, if it's not already out there, and I'm not sure it is, but there will be a checkbox for Administered Helps tool. When you check for a typical Track Direct Services effort, let's just say of individual counseling, a little box will come down and you get to enter the minutes of that counseling session. With the Administered Helps tool, the little time box will not open because there isn't one. Let me know if that does or does not make sense.
Looks like she says she's got it. So Jan, what does ETO stand for?
ETO is a software program that PCADV, PCAR, and PCCD use. The name of the software is Efforts to Outcomes, and this is a shared client management database. Most of the programs across all three funders use the case management portion, and a small percentage at this point use the aggregate portion.
Right. And Jenny has also, Jenny Sigler from PCCD has also written that up there. And she has explained that it's in the Track Direct Services touch point that already exists, not a brand new one. So Cindy says it is there also. Ashley says we shouldn't be recording the second screening using the PSG questions at all.
You record one screening per new adult shelter client.
So the time, but can they add the time when they're recording the time, Jan? The time spent.
You're going to be entering counseling time, whether that's crisis counseling or individual counseling. Use the Track Direct Services effort for the amount of time spent during that 45 or 60 or 75-minute counseling period.
So Adrian, I hope that Jan also just answered your question. Please let us know if she didn't, because it seems like you and Ashley had similar questions.
So, for instance, if you have a 60-minute counseling session with somebody who's a new adult shelter client, or perhaps you have a 90-minute intake, so you would divide up those 90 minutes using the Track Direct Services efforts necessary to properly record that time. Then you would also use the Administered Helps tool checkbox on the same page to indicate that the Helps tool questions were administered. There will be no time. And then you go ahead and save those Track Direct Services efforts. The Administered Helps tool will map to the monthly report, and you're finished.
So ideally, Jan, your intake numbers and your numbers that you have for how many times you have administered a TBI screening should be compatible, right?
They should be, yes.
Okay. Perfect. Those are a lot of really great questions. So we'll also, have more opportunities. We are coming into sort of the end of the webinar, but keep asking your good questions, and we'll definitely address everyone today. So how do we learn more about traumatic brain injury and domestic violence, and how do, the trainers that Fern and Jan have asked to be on this webinar, how are you going to learn to deliver this information to new staff? So some of you have, over the past several years, been to some of the traumatic brain injury and domestic violence trainings that I have sometimes delivered by myself, sometimes with Joe Sterner, sometimes with Jackie Stutz, who used to work here, and now with Jan. So you would have really gotten a full day training of information and tips and delivery. But if you're new or you haven't had the opportunity to attend one of those trainings, and we don't have any planned in the near future, we probably will at some point again, but if you haven't had an opportunity, you can go online to the PCADV website, and you'll want to click on the drop-down that is titled Learn More, and then under that drop-down, you'll go to the PCADV publications. There you will find the TBI and Domestic Violence Toolkit that contains a participant's guide, which is basically an advocate's reference guide. You can keep that in the program. You can keep a couple copies. You can print it off and keep a couple copies in the program, just so that it's accessible by advocates to look at it anytime. There you will also find a trainer's guide for anyone who is tasked with the responsibility of providing training to new staff or refresher trainings. You will also find training slides and a list of resources. Now, we have another learning option that is online through our Online Training Institute, and there are 8 learning modules within the TBI sort of umbrella in that online learning location. So the Traumatic Brain Injury and Domestic Violence Toolkit is comprised of 7 modules. The online learning modules, you'll find 8 learning modules online, and one is an extra that is dedicated to understanding interconnections between sports injuries and dating violence, traumatic brain injury acquired through dating violence, and how those may impact or interact with each other. So again, that one about sports concussions and dating violence is separate from what you would find in the toolkit. So I'm just looking at your questions really quickly here. Yes, Ashley, absolutely. You can email me the new policy, and I'd be happy to review it and provide feedback. Susan, you created a TBI video with input from a local emergency department physician and Brenda Egan Brown of Brain Steps. Great, that's wonderful. That's wonderful, Susan. So, Adrian and Susan, if you'd like to send that to me, feel free, please. And if you'd like us to share it with other programs or anyone else, medical advocates, maybe whomever you would like for me to forward that to. Adrian said, how would we find out where to refer clients? Would we contact the Brain Injury Helpline? That is the best place to start, is contacting the Brain Injury Helpline. You may also find resources through the Brain Injury Association of Pennsylvania or the Brain Injury Association of America. But I would start with the helpline and then go to those other two websites. Should we be implementing this immediately? Is the HELPS checkbox in ETO already? That's what Marcella has asked.
Okay, thank you, Marcella. The standards, the most recent version of the standards was with a start date of July 1st, 2016. So yes, if you have not already begun using the HELPS tool, you will need to do so. I've had to cite programs over the last year for not using the HELPS tool. So yes, this is a very important piece of information that programs need to be doing, and they're required to do at this point, to offer survivors the support and the resources and the referrals they may need to obtain some medical intervention. So yes, this is really important stuff.
Right, right. And Joni has asked, what if they don't have medical insurance? What would be the options? We always say to help them sign up for Medicare, Medicaid, whatever they're qualified for. Maybe the Brain Injury Helpline could provide some suggestions if you call them. So those are the solid places to start. Joe and Jan, do you have any other suggestions?
No, I think what you mentioned, Fern, are really great ideas.
Mm-hmm. Right, right. And, if you're stuck, you may have some colleagues that have had luck with, coming up with unexpected insurance resources or, the Affordable Care Act could lead to some other resources that could be helpful. So start with Medicare, Medicaid, the Affordable Care Act, and the helpline. So the Head Injury Program of Pennsylvania has a great program for covering treatment. Thank you, Ashley. That's a really great resource also. It's called the HIP program, HIPP program, and they can cover up to $100,000 or 12 months of treatment. Ashley, are there conditions on that treatment? Do you happen to know if it had to have happened within a certain amount of time or by a certain, have been acquired by a certain means, or if there has to be a level of severity before they'll cover? There are income requirements, okay. That's important to know. Okay, if someone has a TBI and seeks medical help, then would this qualify as something that could be covered under victims' compensation?
And Jenny Sigler, I know you're on this webinar. Would you be able to provide some insight regarding this?
The victims' compensation, Jan?
Yes.
Yes, that would be great.
And I think Nick may be on this webinar as well. So Fern, I just want to have a conversation with you about this while we're still on the webinar.
Sure.
If someone goes to the emergency room as a result of domestic violence and they are met there by a medical advocate, the person receives treatment in the ER, the ER staff may or may not make a referral to a physician who is a neurologist. In terms of training for medical advocacy or emergency department staff and other kinds of medical surgical staff, is there training on the use of a medical tool similar to the HELPS tool?
Absolutely. So two things, Jan. The first is that ideally the medical advocate would be training healthcare providers to respond and screen for someone with TBI from domestic violence. So the medical advocate would not necessarily be meeting a survivor at the health site, but the hospital would be assessing and recognizing and referring the survivor back to the program. That said, there is an alternate version of the program screening guide called the medical screening guide. And it can be found online in the toolkit, and it is very similar to the program screening guide. It's only very slightly different as far as guidance goes for interacting with healthcare providers rather than interacting within your domestic violence program.
Okay, great.
Yep.
Thank you.
Sure. And I feel like I need to address a couple of other comments up here. Thank you, Ashley, for offering to send that document. And there are some additional conditions. It'll be really interesting to see what those are. So yes, thank you for sending that. And it looks like,
Well, I think our friends from PCCD have probably left the webinar. We will find out regarding the victim's compensation question, whether VCAP would cover any costs associated with.
yeah, I think that's a really great question. You know, I don't want to misspeak and you know, say anything that would be misinformation, so we will look into that. So it looks like someone may be typing, Jackie may be typing, but you know, are there any other questions or feedback? You all have had a lot of really great and important questions and generated a really, I think, thoughtful and informative conversation around how we're doing this. How are we doing this, you know, traumatic brain injury screening, response, and referral requirement within our programs?
Yeah. Thank you all.
Right.
This was a really, really good webinar. I appreciate your thoughtfulness and your questions. And we here at PCADV so appreciate the work you do on behalf of survivors. If you have any questions or need other information from Fern or me or Joe Sterner, who's our children's specialist and is sitting in on the webinar with us, please do not hesitate to drop us an email or give us a call. Our job is to support you in your work with survivors. So take good care of yourselves and each other in the meantime, and we will see you soon.
Great. Thank you so much. And, oh, before you go, we would love for you to just provide us some feedback through an evaluation. And Gianni, our tech support person here, has provided a survey link through SurveyMonkey that we would love for you to fill out and let us know how we did. And Joe might have one more thing to add.
I just want to remind them that if there were multiple people sitting in on the webinar, that they put that in an email to us.
Yes, please send an email to me if you had multiple people so that we make sure everyone gets their certificate of participation and gets your hours acknowledged. So all right, everyone, thank you so much. All your participation was wonderful. And always feel free to reach out to Dan, Joe, or I for any questions you may have. All right, have a good rest of your day. Thank you.